Welcome, ladies and gentlemen, boys and girls, theys and thems, and everything in between, to the Esoteric Wellness Podcast,
where we explore health and wellness from the deep, dark depths of the unknown, the hidden, the misunderstood, the misinterpreted, the misled, and the forgotten.
I am Megan.
And I'm Kyle. All right. Welcome, everyone, back to Esoteric Wellness. We're on episode 7 already.
It's only taken us how many months to get here?
Yeah, it doesn't sound like a very big number, but
No.
it's taken us a while to get there. So today I've got one of my favorite topics to talk about, and probably one of Megan's least favorite. But hopefully, since I have you locked in that chair for a couple hours,
Yeah.
you're going to have to let me finish what I want to say. Maybe it'll be an easier topic for you
Maybe
to
I'll
talk
get
about.
struck down or something.
So today we're going to talk about pain, just pain generally, and then we'll get into more specifically chronic pain. And as Megan can attest to, some of what I'm going to introduce to you guys today is challenging.
You guys are lucky this is not a video recording, because if you could just see my face right now.
But if you remember our last episode, this is exactly what we talked about.
Yep.
This kind of pursuit of knowledge requires us to question our own beliefs and understandings and be willing, if the evidence supports it, to set that aside and replace it with something new.
And not strangle your partner in the process.
And I think with the concepts we'll talk about here today with pain, once you really understand it, I think it's a more empowering perspective to have. Not at first when you feel like everything you've been told is wrong, but once you really get past that and start to understand it for what it actually is, I think it's definitely a more empowering perspective to have on pain. And pain is one of those things that we all deal with, right? It's part of the human experience.
So fun.
There are very few people out there who actually can't feel pain. And, well, I won't get into that yet.
And neuropathy and whatnot, but whatever.
So we're going to start by just kind of digging into what pain is and how pain works, how it happens. And I think right there is where most of the misunderstanding lies. They're really... Anyway, I'm getting ahead of myself.
No.
So are you going to be able to bear with me for 2 hours here?
For almost 20 years.
Just to give you guys a little bit of background, this is something I talk about a lot because it's something I work with a lot. And Megan gets frustrated with me.
Not only I deal with pain, like we all do. And as Kyle said, when your way of understanding life and how things are is challenged, it can be hard to take that. And we've discussed this many times in previous episodes. And when it's coming at you frequently in your home, I'm staring at you. It can be hard. And anytime you say something or you hear something or you're watching something and then your spouse spouts off about, well, rah, 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 you tend to get a little exasperated, it's a little, yeah. Anyway, so I hear this a lot. It's what he does. It's also like when I get on my political rants. And what? What was that? What's good for the goose is good for the gander.
We both have our rants.
Yes, we do.
Okay.
Yes, we do. So, yeah. So, yeah, I'm going to lock in for 2 hours, and then you're going to be in for a big one, after this. So,
payback.
Yep.
Anyway, so first of all, who the hell am I to talk about pain for 2 hours to anybody?
I ask you that a lot.
And that's what Megan asks me a lot. It's like, why do you have any business talking about this?
You don't.
Because, well, I'm not a neuroscientist. I'm not a medical doctor.
I tell him he's my husband and go away.
However, I do on a daily basis work with pain. I teach this concept to people as part of the recovery process from chronic pain. Just having this understanding of how pain works is a big part of that process. So I've done a lot of reading, I've had a lot of training on these concepts. I'm not doing the research itself, but I do have a pretty thorough understanding of it at this point. There's still, we're not going to go really deep into the weeds here on neuroscience today
Please don't.
because some of that is still even above my head. And we don't need to give people an understanding of these concepts. But once we get into like what each individual neurotransmitter does and the specific nerve pathways, none of that is that important to understand, to have this understanding of pain. I mean, that stuff's really interesting and I'm trying to learn it, but we're not going to go there today.
Okay.
Um,
I appreciate that.
when I was initially planning kind of this episode, that was my original intent.
He asked me, he's like, so do we need to do? I was like, no.
And I kind of had to step back and think, what's going to be most beneficial to our listeners. And it's not to give them a biology lesson.
So my thought is there might be people driving while they're listening to this, and I don't need them falling asleep at the wheel.
Wow.
I'm sorry.
So we'll scratch the surface of that stuff, but more just so people can understand at a high level what's kind of going on. But we won't get real deep into the weeds.
Just a little tickle and then move along.
Because in reality, we would need much longer than 2 hours to do that.
Listen, I have to color my hair later. I don't have time for that.
So let's just start with what the hell is pain? If I asked you, Megan, what pain is, what would you say?
Like when I try to get out of bed in the morning. No. I know what it is because you have ranted and ranted and ranted about it. But as like a lay term, like what a layman's person would be, sure. Pain is what happens when you stub your toe. Like that's that reaction, that feeling you get when you hurt yourself. It's usually something negative. Oh, I cut my finger and that hurt, or oh, I touched the stove, it's hot. It's a bad thing that happens when it's a cause and reaction.
Mm-hmm. So I think you said it's a feeling.
Yeah.
The sensation.
Yeah.
And that's entirely accurate.
Yep.
But
I know better.
Where a lot of the misunderstanding is why that happens or how that happens. So two very important points here with pain is a sensation created by the brain.
Mm-hmm.
And pain's purpose is always, 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 always to protect our body.
Mm-hmm.
Okay. Pain is a sensation created by the brain. Pain's purpose is protection.
Mm-hmm.
All right. I'm going to say that over and over and over again.
He does. Let me tell you, he does.
Now,
it's all in your head, kids. It's all in your head.
Well, no.
No, that's my rant.
It's not just in your head.
That's what
we'll get into. It's actually in your whole body.
I'm always screaming at him. It's in my head.
Your brain plays a large role in this, but there's a whole lot of other things going on, which we'll get into. But the old idea of pain, and it's called the Cartesian model. We're going to bring up Rene Descartes again in this episode because that's where this model comes from. That's how old that actually is. In the 1600s, that's how long we've looked at pain traditionally in that way, where there's this one-to-one relationship between pain and tissue damage, where tissue damage is directly causing pain. You cut yourself, you stub your toe, causes damage to the tissues, which leads directly to an experience of pain. Well, we now understand through neuroscience that it's way more complicated than that. um, Now we look at pain with this what's called a biopsychosocial model. So we have biological components, we have psychological components, and we have social components. Why are you laughing?
Because you're over here talking about Rene Descartes and biological psycho things and whatever, and I'm over here in my head thinking SpongeBob, and I'm going Boo Boo's A and thinking about Weenie Hut Juniors. I'm sorry.
Okay.
This just shows you the different levels that we really have on this show. You've got you over here wanting to talk about neuroscience, and I'm over here going Weenie Hut General.
Boo boos.
Boo Boo's A.
Yes.
No weenies allowed.
Oh my God.
I'm sorry. I just
You're making this hard.
I know. Okay, go ahead.
So when we feel pain from our boo boos, there's a whole lot of variables kind of all interacting to determine if we feel pain, how much pain we feel, where we feel it. Basically, everything matters. And this is because our brain assigns meaning to everything. All our experiences, everything we know, everything we've heard, we've been told, our brain is like building this library, building patterns, assigning meaning to those patterns. And if that meaning suggests that we need more protection, it can increase pain or cause pain. If it suggests that we need less protecting, it can decrease pain. Now, for any boo boo, you have a huge number of these factors all coming into that experience of pain at the same time, right? So biological factors would be if it's an actual boo boo, if there is tissue damage, that's one variable.
I love that you're leaning into this. Thank you.
Yes. Our current state of health. Are we ill? Are we fighting off an infection? Are we suffering from some other chronic disease? That comes into play. Our level of physical fitness. Do we have past traumas or injuries to our body?
Also, please ignore the fact that my cat sounds like he's currently dying outside of the door.
Hopefully that doesn't pick up.
Yeah, well, if it does.
Are we on any medications? And then psychological factors like our past experiences with pain. What are our beliefs about pain? Do we have past traumas or traumatic experiences? Do we catastrophize pain and other things? What are our pain coping skills that we've learned throughout our life? Are we suffering from other psychological issues like depression or anxiety?
So is this like when you stub your toe or step on a Lego, the world ends, but I get tattooed and it's not bad at all because it's something I enjoy?
Exactly. Yes.
Huh. Okay.
Exactly.
Makes sense.
Exactly. And then we have social factors like what are the cultural norms and beliefs about pain? What's acceptable reactions to pain? What's our work environment like? What are the relationships we're in right now? How are they difficult? Are they healthy? Environmental factors, what level of satisfaction do we have with our life currently? All these things matter to the brain. And they can suggest to our brain whether or not we need more or less protection. So
That's a lot.
I'm glad you brought up the tattoo example because if I just took a needle and started stabbing you right now,
I'd be kind of pissed.
it would probably hurt like hell.
Yeah.
But you can go to a tattoo artist and get stabbed thousands of times over and over again. It is not a big deal. It still hurts.
I pay the man for that.
Right. But it has a totally different set of meaning around it. So you have a totally different experience with pain. And we'll get into a lot more examples.
By the way, all the guys I've been tattooed by say women take it so much better than men. So stuck on that.
There are gender differences as well that we see across the board. But yeah, so many differences with experiences of pain. So kind of an analogy I like to use with this is We've used this analogy kind of a little bit with some other things, but we have kind of an internal threat bucket.
Oh yeah, my bucket.
Yeah.
I talked about my bucket.
And all these things with meaning that suggest we need protection start to fill up that bucket. And we have kind of spigots on the bucket that empty it out with our healthy coping skills.
What are those?
And the other things that have meaning that suggest we don't need more protection. And we can also have unhealthy coping skills that kind of just drain right back into the bucket, for example.
Those I understand.
And once that bucket reaches a certain level of fullness, our brain starts doing things to protect us. That could be pain. That could be anxiety. That could just be generally feeling uncomfortable. It could be other physical, almost like illnesses. Like a lot of people get like intense gut issues with intense stress.
You're speaking my
I'm
language.
looking right at you.
I
Megan.
know. I say I am understanding every bit of this. Keep talking.
So we could even expand this discussion out to way beyond just pain.
I'm just going to say my bucket is tiny and defective.
Pain is just one tool of many that our brain can use to protect us.
Mm-hmm.
And as we'll talk later on, changes can happen that kind of change the size of this bucket and kind of the size of the things filling it up, the size and flow rates of the spigots emptying it out. All this is subject to change, which
Is
we'll
that
get
in the
into.
fine print somewhere?
We'll get to the fine print.
Okay.
But let's get into some fun examples of kind of demonstrating this concept that pain, as far as the experience of pain, can be totally different person to person. Even if we are talking about tissue damage, you can have the exact same injury, two different people, totally different experiences.
Absolutely.
And we've kind of wrongfully called this like pain tolerance. Like somehow they're able to take more pain than someone else. And that's not really true at all.
Well, it cracks me up when you go to the hospital and they give you the little smiley face scale.
This cracks me up because how do we gauge the severity of so many things medically?
Yes.
Is how much pain we're in. But I'm here telling you that is totally unrelated to the medical thing going on much of the time. There's so much more affecting it.
Well, can I do an interjection on that itself? So I read a study saying that when women go in versus when men go into the hospital, and they ask women and men to rate their pain on the little smiley face scale, that when men rate their pain higher, they take that more seriously than women do, because men are much more macho and don't rate their pain higher. So when women could be, have their leg mauled off by a bear and don't rate it as high because, we don't want to be a burden or whatever. And they take our pain less seriously than they do men. And that has been like proven across the board. They did, I can't even remember. I read this article quite a while ago, but the study showed that they take it less seriously.
There's so much cultural stuff.
Yes.
Gender things wrapped up in pain.
Yes.
And it even affects our experience of pain as well.
I was like, really?
Yeah.
What? Because I can push a human out my body. My pain is less than yours. Whatever.
So here's the one everyone can do on their own right now as they're listening.
Okay.
So take a finger, bend it backwards. Right?
Do I have to do this?
You can.
Okay.
Do it.
Peer pressure.
Yours goes back much farther than mine.
I'm a very flexible person.
But at some point, you're going to feel pain, right?
Okay.
Are you feeling pain?
Hang on. Okay, there.
Wow, she's got to contort in all kinds of weird ways to get it to go that far.
You like that?
Now you're feeling pain, but you've done no damage. Would you agree?
Sure.
Yeah. As soon as you stop, the pain goes away, right? There's no lasting pain, no lasting damage.
It's going away.
So this is a great example of pain is protective. That's your brain saying, hey, knock that shit off.
That's as far as you can bend it.
Yes, that's as far as it goes. I feel
that's
pain.
Sad.
So your brain's going, hey, that's far enough. Knock it off, or you're going to cause damage.
Okay.
All right. And you know how that's happening. There are sensors all throughout our body, sensory neurons, or sometimes called nociceptors. They sense all kinds of different
No
things.
C,
Noci,
like no seams.
no, NOCI,
Oh, that's no fun.
noci. Anyway, the name's not important, but these detect all kinds of things like pressure, temperature, things like that. And they're basically danger sensors. If they're detecting something that's not as it should be, they start firing and sending signals through the nervous system to the brain.
It's the oh no button.
Yeah. And we'll talk a lot more about these in a little while, but the brain sees those messages and interprets them as dangerous. And once the brain sees enough danger from those messages, it turns pain on. So in this case, bending the finger back is probably mainly pressure. Yeah. Make fun of my little,
I
yeah.
That's sad.
That's as far as it goes.
That's it looks like you're just counting off numbers. One, two.
But those messages get to the brain, that threat bucket gets filled to that pain line, whatever your brain has decided that is, and it turns pain on. Another interesting example is they've actually found that violinists, so people that play the violin professionally, that's their livelihood, their left hands are more sensitive to pain than their right hand.
Oh yeah, they're pressing on strings.
Well, think about it. That left hand is more valuable
Uh-huh.
because you need more dexterity to manipulate those strings than you do with the right hand,
Uh-huh.
just to move the bow back and forth.
Yeah.
In reality, you probably lose fingers on your right hand and still be able to play a violin. But if,
Something happens in
anything
that
gets
hand.
messed up on that left hand, it's really going to affect it.
Okay, so now I want to know if my right hand's more sensitive.
I couldn't find any studies, but I would assume that people that are, have one dominant hand versus the other, that dominant hand would be slightly more sensitive to
Right.
pain.
I mean, because if something happened, well, that's like a girl I worked with broke her right hand. And I mean, I do hair. So she couldn't cut. And that's a big deal. I mean, if I break my other hand, yeah, that's going to be tough because I hold a brush with that hand or a comb with that hand, but I can always slide a comb and like, hey, hold it with my fingers,
Right.
but I can't cut. So I wonder if, that's interesting.
Yeah. And again, I couldn't find any studies, but I would imagine like a guitar player would have the same
Same.
thing. Um, and you could even imagine like somebody who had both their hands are important, like a surgeon.
Yeah.
They're probably going to be more sensitive to both hands
Yeah.
versus, an average person who their hands aren't as important to them.
Oh, that's crazy.
So
Hmm.
the brain is assigning more value to one hand versus the other, so it protects it more.
Because the body knows that that's your livelihood and don't.
Right.
I've never thought about, your body knowing that this is your breadwinner here. Don't fuck it up.
And you could even, look at another example um like genitals are more sensitive than the rest of
Oh,
the body
yeah.
because they're more valuable.
That's well, we know how men are. You even look at them wrong and they're flinching.
um Another example, you probably even heard of this, is phantom limb pain.
Yes.
So this throws that one-to-one relationship between tissue damage and pain out the window because you're feeling in pain in something that's not even there.
Hmm.
So what could possibly be causing it?
The brain.
Well, it's definitely not tissue damage because we've removed the biological factors completely.
Hmm. There's a really good episode in Grey's Anatomy about that. Pretty my
What about it?
my cat's dying out there. Sorry. So one of the doctors loses a leg and is dealing with phantom limb pain. And they end up, she's a surgeon. And it's been years since I've seen it, but if I remember correctly, if this is a spoiler for anybody, I mean, you're way behind on the time.
It's
So
just
this
pretty
is on
old at
you.
this point, isn't
Oh,
it?
it's still going.
Is it?
But this part, oh yeah. But this part, it's been years. So since she's a surgeon, she's sitting there and she takes a scalpel and she stabs her prosthetic in the leg. And it's like, look, it didn't do anything because it's not there. They also did like the whole mirroring thing. But
Yeah,
yeah,
that's a common treatment.
yeah. But the mirroring, it didn't work and stuff. So she took a scalpel and stabbed herself in the leg. And it's like, look, it's not there. It's a prosthetic. There's nothing, you know. And that was kind of a recognizing between the eye, the brain, and the leg that it is no longer the leg.
Yeah.
Pretty cool.
Some more examples. Again, pain being protective, not necessarily associated with tissue damage. So, with the most injuries, say a sprained ankle,
Mm-hmm.
you know, that actually does cause damage. And most sprained ankles take, somewhere 3 to 5 weeks to fully heal that damage that's been done.
Mm-hmm.
Yet, most sprained ankles for most people only hurt for about a week. So, the pain duration is not matching the tissue damage duration. But when we look at it through this lens of protection, it makes more sense because the pain is there long enough to keep you from injuring it further. And once it's healed enough that that's not as much of a risk, pain goes away. But I imagine there's probably a window in there too where if, walking is no longer painful, but if I wanted to start running and doing all kinds of other crazy things, the pain would probably come back because I'm upping the level of risk. So that's another example. Here's another cool one that you can do at home. So most of us could probably, squeeze the tip of a finger, one of our own fingers, and you can probably crank down on that as hard as you can with your other hand. And yeah, it's going to cause some pain, but I'm literally squeezing my finger as hard as I can right now. It hurts a little bit, but I'm able to do that. Now, give me your finger, Megan.
No, I don't want you to put me out.
Let someone else squeeze your finger as hard as they can.
No.
Chances are you're probably feeling very wary about that. And what they found in labs is you're going to feel more pain as well. And they've done this very much more in a controlled way with a clamp that clamps to the exact same pressure. But at first, you're turning it on, you're manipulating it. You have, a button that would stop it right away. And then the next step is having someone and trust operate it.
I don't know. I don't even trust you. Get out of here.
You feel more pain. And then the last step is to have a total stranger operate it. You can imagine you letting a total stranger squeeze the tip of your finger as hard as they could. Most of us wouldn't even do it. But a lot of people won't even get to that same clamping pressure when it's a total stranger because their brain's like, nope, we're done.
My first thought was your brain wouldn't let you press on yourself that hard versus I don't want to break
You
my
don't have to do
nail.
your nail, dude, like your knuckle or something. You can probably squeeze it as hard as you can, right?
Yeah.
Yeah. Because you're in total control.
That was weird.
And now she's going to let me do it.
Ow.
Yeah.
Okay.
Now, I may be a little, we probably have differing amounts of strength as well, but
I'm a strong, independent woman.
yeah, I didn't squeeze it all that hard.
Seriously?
Yeah.
Okay.
The threat, the level of risk went way up. So your brain caused more pain.
Well, apparently my brain does not like you very much.
That's normal, though. That's what they find over and over and over again. Right?
Ow.
It still hurts.
I'm like,
Another fun example was they took a metal probe that was cooled to a very cold temperature and would hold it on someone's skin.
Hmm.
And on this device, they made it would have a red light or a blue light.
Oh, I see where
No
you're
difference
going.
in temperature, no difference in the probe. The only difference was the color of the light. And
Okay.
almost across the board, people would rate the test with the red light more painful than the one with the blue light.
They would think it was hot versus cold.
That, and I think culturally, red is more often associated with danger.
Hmm.
I mean, look at most danger signs, they probably have red on it.
Stop is red,
Exactly.
things like that.
Versus blue is seen more of a, a safer color.
Hmm.
Um, so that's kind of those cultural factors coming into play. Just the color of the light has enough meaning to change
Hmm.
the experience of pain.
Psychological things around
Exactly.
this is.
And we could do this all day with examples of pain varying based on certain variables.
I love how we're torturing people for something that's great.
If you want to torture people and not go to jail, go to school for psychology, apparently, because they do this all the time.
And here I go again, associating things with things. Ghostbusters. I think of Ghostbusters where he's in the lab having him read the cards and he's shocking them.
I always think I've watched a lot of presentations from a neuroscientist named Lorimer Mosley, and he always makes the joke about these studies that they're seemingly normal, healthy individuals, but he's like, let's be honest, they volunteered for a study that was going to inflict pain.
Yeah.
They're probably not normal individuals.
Nope. Oh, well,
But
we all got
other
something, don't we?
examples like you know, I remember one like the attractiveness of the person conducting the study
Hmm.
affected someone. Well, they were trying to measure pain tolerance, which, as I said, is probably we were measuring other things. But like if the um, person doing the experiment was like attractive female, men would suddenly have a much higher pain tolerance.
Well, yeah, they got to be macho in front of a woman.
Right.
Hmm.
But they keep finding that all these seemingly insignificant variables are greatly affecting the outcome
Hmm.
of the test.
Well, kind of slightly off topic, but like when we were just on vacation and I was discussing that study of people presenting facts in different accents, and the people didn't find they thought the person with the the English, the British accent, found the facts more compelling and more believable versus the standard American accent, or Midwestern, the plain accent was okay, and then the Southern accent, they didn't think they sounded as smart or the facts were as believable. See, those are those psychological things. It's
Yeah, it all matters.
uh-huh.
It all affects it. And that's really the point we're trying to make here. Um,
Our brains are stupid,
another
but
fun
beautiful.
example, if you've ever seen it, it's called the rubber arm experiment,
Yes.
where they rigged this up in a way from the person's perspective that make this rubber arm look like their own, and they hide their real arm.
Hmm.
And they initially they'll touch the rubber arm and their real arm
Hmm. Looked like a
at the same
feather.
time to kind of train the brain to associate that rubber arm as their own. And then eventually you can just stimulate the rubber arm and they actually feel
I love when they
sensation.
stab it.
And then, yeah, they usually end it with like smashing
A
it with a hammer
hammer,
or
yeah.
something, or burning it or stabbing it.
And then they like scream
And
and
they feel
they,
real pain
yeah.
from that.
Well, that again, going back to that Grey's Anatomy thing where
They were kind of doing the opposite. Yeah.
yes, she was trying to associate like this is not your leg,
Right.
you know, and it just, it's wild to think that our brain, you have this lump of goo, by the way, which I just learned has no blood in it. There is no blood cells, no nothing. Your brain has, there's none. There's no blood product. That's where your blood-brain barrier comes in. There's no blood
Around the exterior
stuff
of the
in
brain,
your
there is.
brain. It's a goo full of electrical
Well,
crap.
we'll get into what that goo is made of.
I know. I'm just saying, like, this stuff is what controls your body and can make you think these things.
All right. Well, we are up to our first break. I'm going to make Megan watch this rubber arm experiment video, and then we'll talk about
You've
it
done
when we
enough
come back.
experiments on me so
We're
far.
not going to actually do it. I don't have a rubber arm.
I probably do somewhere,
I'm
let's
not
be
sure where you
honest.
get one of those, but
I probably do. I've got a lot of mannequin heads
you
and
got fake heads we
I
can
do.
do something with.
I have right there's one.
Hmm. All right, we'll be back in a few.
Bye. Welcome back to Esoteric Wellness. And we're coming back into our pain segment here
Ouch.
and boo-boos. And we were just discussing in our last part what pain is. And I know that's a broad area, but we're kind of discussing it and I don't know. How do we want to just just for the lay people, kind of what pain in general. We're not getting into that because I will fall asleep.
Pain is a sensation created by the brain.
Yes.
Pain is its purpose is to protect us.
There you go. He does all that stuff. I'm just here for fun.
Okay,
Yep.
let's jump back into it.
Okay. Rubber arms.
So back to the kind of the old model of pain, this one-to-one relationship between tissue damage and pain.
Mhm.
If that were true, we should expect to see, if we plotted it on a graph, pain severity versus injury severity, we would expect to see kind of a linear progression. As the injury increases in severity, the pain also increases in severity. Right?
You would think so.
That's totally not what we see. Not at all. What we see actually is kind of this very steeply shaped kind of like an upside down U. Okay, where very quickly that possible pain severity jumps up to a max
Hmm.
with little to no injury. And that holds true until some point where it just drops off.
Is that shock?
Well, that's how it's often been explained. But when we look at pain with this perspective, it totally makes sense. So, first of all, any amount of pain is possible for any injury. Any amount of pain is possible with no injury. I just want to beat that into everyone's brain. We can feel pain with no injury, right?
Yep. We've had that
But
conversation.
when an injury is truly life threatening, they tend to create little to no pain, which is opposite of what we would think.
This is the body's way of
Now, remember,
preserving.
what's the purpose of pain?
Danger.
To protect us. If I have suffered a truly life threatening injury,
You're going to know it.
how is giving me pain on top of that going to protect me?
I think you know.
If my arm has been lopped off and I need to get to help, me writhing around on the ground in pain is not helping me do that.
Is this where like your adrenaline comes in and you like, gotta go?
Well, it's not really that. I mean, I'm sure like adrenaline is playing a role,
Sure.
but it's not a leading role.
Okay.
What's really going on is your brain is interpreting the situation, and it's like pain is not helpful right now.
Oh shit, we gotta run.
Right. And we can find story after story after story of this. Like, we hear stories of war heroes on the battlefield being shot multiple times, but they don't feel any pain.
Mm-hmm.
So that they can drag their comrades to safety. But once they're safe, there's the pain. Because the brain is always adjusting, learning, weighing the circumstances at play. And it's not until pain becomes helpful again that it turns it on.
Hmm.
It has nothing to do with the amount of tissue damage. Well, not nothing. I mean, that is one thing being taken into account, but not the only thing.
Sebastian agrees.
Weirdly timed me out.
That was a great.
Um,
Oh,
so your friend's an EMT, right? Or a paramedic?
my bestie. Yes.
She ever told stories about like really bad injuries where they didn't seem to be feeling any pain?
I'm gonna have to ask her.
Yeah. I didn't know if any came to mind for you.
I think there was one guy that was like freakishly shot a few times and just kind of kept going. Yeah. Yep. I'm gonna have to ask about that tonight.
I always think of a story um, a neuroscientist was telling when he was doing his residency research. He was observing in an emergency room, and a guy comes in to the ER waiting room with a hammer lodged in his neck. The claw end of the hammer is in his neck. Okay. And
Oh,
he
weird.
very apparently had a very good sense of humor about it. He was telling jokes and teasing his buddy, and he very clearly wasn't feeling a whole lot of pain. Okay. And that's probably, a life threatening injury.
Depending on where in the neck it's at. Yeah.
Yeah. And so they're in the waiting room, and this guy's joking around with a hammer hanging out of his neck. And he's pretending to be swimming through the chairs and stuff. And he's saying, I'm a hammerhead shark.
Oh, for God's sake.
And he whacks his shin on the coffee table
And ow.
and very clearly feels pain in his shin.
You're shitting me.
No.
Good God.
So this neuroscientist is like, well, how do we explain that? Because the old idea of, oh, he's in shock, he's not feeling pain, doesn't work there because he is feeling pain somewhere else.
You know what? It reminds me of the thing, you know how we always joke around and say somebody's like, oh, I got something. You're like, oh, you want me to punch you in the arm so you'll forget about it? We always say
There
that.
might be
It kind
something
of,
to that.
exactly. It's like, oh, I got a headache, or oh, this hurts. Oh, you want me to punch you over here? That might actually, yeah. I've never thought about that until now.
But that demonstrates the brain's ability to differentiate, this injury is life threatening, pain is not helpful. This injury is more minor, pain is helpful.
We'll distract you with this one.
Thing, quit swimming around the waiting room like a jackass.
You dumbass. Stop that. Sit down.
And the brain is able to make all these decisions simultaneously with pain.
My God.
And this is the only kind of model of looking at pain that can explain something like that.
I want to know why the dude is sitting in the waiting room and not being rushed back to triage.
Good question.
Yes. This is our healthcare system, people. Oh, we can be better.
Well, he didn't rate his pain very high, so that didn't determine it was an emergency.
He was only like a 2. It's fine. God. But sir,
So, again,
it was a hammerhead shark.
pain is always the brain's decision.
Mhm.
The brain decides, do we turn pain on? If so, how severe is it? Where is it? How long does it last? It's always a decision based on a large number of factors, not just, is there something physically wrong in my body?
I'm a control freak. I don't like that
Why?
because I'm not in charge of the show here.
Your brain's in charge.
Yeah.
Well, you raise a good point, though,
Of course I do.
that the part of the brain doing this is not our logical analytical mind.
No, it's not. Believe me, I know I deal with it every
We
day.
can't, well, you can you can influence it with thought, but you can't control it with thought. Like I can't think pain away. I can't think myself into pain. Thoughts do play a role. They do contribute. They do influence that, but they're just one factor among many.
Mm-hmm.
Um, so yeah, the part of the brain doing this is, it's our lizard brain, more in the brain stem. Its job is to keep us alive, to see the next day. It doesn't give a shit whether we're happy or not.
Nope.
If you live to see the next day, it's done its job. It's a success as far as it's concerned.
Stupid brain.
And because this is the older part of the brain, many of the pathways and things directly affecting and controlling pain, they're not going through our frontal lobe where we have consciousness,
Fully
like thought,
developed. Yes.
because all that stuff was developed much earlier in our evolution. So it's something I run into a lot working with people is they think they can just think themselves out of pain. And yes, that's part of the process, but it's a small part. It's not, you got to go way beyond that. You got to reach a different part of the brain.
We got to talk to those monks that do that serious meditation and all that jazz.
Yeah, that's some interesting stuff too. All right. So as we know with the brain, the brain learns, it adapts. Now, when we talk about this pain system, we could refer to it as a danger detection system. So it's not just the brain making decisions, there's a whole lot of parts and processes involved in detecting danger. And we're going to start to look at what these are. But the key point with this danger detection system is that it learns. So you could have one injury today and have a certain level of pain. You could have the exact same injury tomorrow, have a totally different experience with pain because that danger detection system has learned. That cat is annoying.
He misses me.
He doesn't care the rest of the day until the door's shut.
It's because I'm in here. He doesn't care about you.
If we let him in, will he be quiet?
We can try. Let's see. Sebastian's joining the fun.
You win. Are you happy?
Yes.
Oh, gosh.
He's happy. He's going to come up here and sit with us now. Anyway, pain. You were saying something about pain?
The danger detection system.
That's right.
So let's just compare this to human behavior. If you became aware of a danger, like say tonight our house was broken into.
Oh, wow. Let's just manifest that right into the universe.
Well, hopefully that doesn't happen. But if that did happen, what kinds of things would you do after that as a result?
After that, I'd be pissed off because you didn't set the alarm. I would call the police.
Your first reaction is to blame me.
Yeah.
I mean, like the next day, it's been resolved, all that.
Have the police been called?
Yeah.
Take account of what was stolen.
Okay.
Okay.
What kind of changes would you make?
I would make sure I would set the alarm and not you.
You would probably
get a big dog.
Get a guard dog, install better locks, stronger doors, windows, better alarm system, right? You would want to get better at detecting and preventing
Preventative.
that danger that you are now fully aware of, right?
Yep.
Well, our internal danger detection system does the same thing. When it starts to see danger, it wants.
But we're not getting broken into because I have a very good alarm system. I'm
What are you talking about? Our house?
Yes, I'm trying to counteract the crap you just put into the universe.
Okay.
Let me be.
So our internal danger detection system identifies danger. It wants to get better at detecting that danger and preventing us from encountering it.
Yes.
Right. So our protective buffer over time can grow if it keeps seeing danger. And this is where we start to talk about chronic pain versus acute pain.
Mm-hmm.
So what chronic pain really is that protective buffer has grown to such a degree that it is now overprotected.
Uh-huh.
You with me?
Yep. The cat's just trying to talk into the microphone.
And when our danger detection system has become overprotective, that can translate and create persistent or chronic pain.
I know all about that.
Because once it becomes overprotective, now it's seeing danger everywhere. It's seeing danger where there is none. Uh, what were previously non-threatening stimuli can now become perceived as dangerous.
It's the crazy lady on the block that's gone overboard.
Yeah, I mean, we could take that breaking in to the next level. Now I'm super paranoid of my neighbors. Every sound I hear outside
Don't rub on my microphone.
is scaring me.
Yeah. We've got floodlights, guard dogs, chain link or barbed wire.
I'm calling the police, every other night because of some noise I heard. I got floodlights outside pissing off the neighborhood. um because my paranoia, I become overprotective. I'm seeing danger everywhere. I'm anticipating danger everywhere. And our internal danger detection system can learn to do the same thing.
So what do we do with that?
Well, we're going to get into how that happens.
Okay.
So that's not just a decision that happens in your brain. I'm going to be overprotective now. There's real physical changes that occur in the brain, in the nervous system, and in the body that create this process. That cat's horribly distracting.
He is learning about pain.
So one thing with chronic pain that we see all the time, and it's kind of tragic because it leads people down the road of chasing perceived problems that aren't really problems.
I'm feeling targeted.
We'll get to that in a moment.
Oh.
So what I call normal abnormalities. So the human body is not perfect. We're born with abnormalities. We develop abnormalities as we age, normal wear and tear, things like arthritis, wear and tear on our joints, past injuries that have healed, but
Sure.
that leaves an abnormality of some kind.
That old football injury.
So you can imagine as this danger detection system becomes overprotective, at some point it starts zeroing in on the weakest link in our body as a problem.
Makes sense.
And it starts creating pain. So I'll use back pain because back pain is by far the most common form of chronic pain.
You can talk about that.
And it's something I can very personally relate to because
yes, you can.
I have it myself. So they've done studies where they did MRI scans of spines of people with no pain at all, no back pain.
Mm-hmm.
80% of the time, what did they find?
Back problems.
Degenerated discs, bulging discs, spinal stenosis, ruptured discs, and all the classic diagnoses we hear with back pain.
Mm-hmm. And they had no clue.
They had no clue, no pain from it. And interestingly, some of them, after learning that, developed
pain.
That's a whole nother thing.
You planted the seed.
Exactly. So these things are normal signs of aging.
Sure.
I think pretty much everybody develops them as they age, depending on your lifestyle, how hard you were on your body, these kinds of things. And as that danger detection system becomes sensitized, becomes more overprotective, it starts to see those as a problem and creates pain as a result. Now, the tragic part of this is people do all kinds of things to correct these normal abnormalities, have surgery, physical therapy, injections, and it doesn't fix the root problem, right? Our danger detection system is still overprotective. So either the pain persists or it moves somewhere else. It finds the next weakest link after we fix that one. So I see time and time again, people have surgery after procedure, and they're starting to feel like, what is my body falling apart? And it's just that danger detection system zeroing in on each weak link in their body.
Because it's just running rampant at this point.
Right. It's so overprotective. It's seeing the normal state of the body as dangerous. And so a little bit about myself, I had a spinal fusion surgery in my lower back at 20 years old.
The month after your 21st birthday.
Was it?
It was 1 month after your 21st birthday.
Okay, at 21 years old.
Yep.
I've been telling everyone the wrong age.
You were barely 21.
But still.
It was in June.
I had dealt with back pain on and off, probably over a year before that, and even way before that in middle school is when it originally started. I had back pain for a while, and then it went away once I got into high school for several years, and then it came back. I now understand there was probably nothing seriously wrong with my back that required surgery. And even after I had that surgery, the pain persisted. And I remember specifically being told multiple times, this is as good as it's going to get. You're just going to be in pain the rest of your life. This will just keep it from getting horribly worse. Now, fast forward to today, most days I have no pain.
Yeah.
I still have flare-ups every now and then.
And you tell me your brain's just being stupid today.
Yeah, I look at it totally differently now. I have titanium and steel parts in my spine, and I look at it now as my spine's stronger than the average spine. Not that, and I've been told this, like I should be careful, or I should, somehow fragile now. And, that's a belief that suggests to my brain that I need more protection and can actually drive pain. So now for me, how I got out of pain was not getting out of pain was never my goal, I guess. I made a lot of changes in my life and started down this path of changing career and kind of a spiritual journey in a lot of ways as well. And, I made a lot of changes, and I now understand we're changing a lot of these biopsychosocial factors contributing to my pain, and my brain learned to be less protected. So today, I don't have pain most of the time.
I remember what it was like before you used to have to sit with a pillow behind your back. You couldn't sit for very long. Your legs were still going numb. I mean, you were a completely different person then.
And that's a story I hear over and over and over in so many people. And
it is rare that I ever hear you say that you have a day where you're in pain now. Rare.
Because even when I do, I don't talk about it in that way.
Yeah.
But so many people are chasing these surgeries, chasing these medical answers, but we're totally missing the root cause. Because this old idea of pain still is so pervasive, even in the medical community. And the neuroscience we're talking about here is not like it didn't happen. It wasn't discovered last year. It's been around for a while now. And it just hasn't infiltrated how doctors treat patients yet. So it is changing. It's getting there. It's happening, but it should have happened a long time ago. Sad to say. So I think we'll take another break here, and then we'll jump into those changes and where those changes are happening, how they're happening. How does this danger detection system become overprotected? All right, we'll be back shortly. All right, and welcome back to Esoteric Wellness. Starting the second half of today's episode. Now we're going to jump into kind of the biological changes that lead to our danger detection system learning and becoming overprotected. So, first, I want to kind of talk about what initiates this whole thing. What, so we need some kind of perceived danger and one that lingers for a time. Because, stubbing your toe on the coffee table isn't going to cause this unless maybe you're stubbing your toe on the coffee table every single day for a period of, a few months.
You might want to move that coffee table.
But yeah, you'll probably correct that some other way. So there's not one kind of path into an overprotective danger detection system or chronic pain. There's so many different routes that I've seen. I've talked to people, and it's always complex and multifaceted, but a lot of times it can start with an injury and there's other stressors happening. Sometimes there's no injury at all, and it's just, stressors from other factors of life. Sometimes it starts in childhood with, experiences with trauma and abuse and things like that, that really train our danger detection system to be on the lookout for danger because we go through very dangerous experiences. It can be big changes in life, good or bad. It can be death of a loved one. It can be loss of a job. It can be retirement. Anything that's going to cause things to happen in our life that our brain assigns meaning to, that suggests we need protection. And that reoccurring over time, our danger detection system is going to learn and try to get better at detecting and steering us away from that danger. So how that happens for each individual is different. And there's always, like we've been talking about, there's a lot of factors involved. So it's not just like I had an injury and now I have chronic pain. That might be part of it, but there's a whole lot of other things going on. And, I say something all the time that it's never truly about just the pain. It's about so much more. And again, what that is different for everybody. But so what happens in the body to cause this? So we're going to start with changes at the neuron level. So the sensory neurons and nociceptors we were talking about earlier that are all throughout our body, that their job is to detect danger, and when they see it, alert the brain.
Yeah, when you squeeze my finger.
Exactly. So the pressure sensors in your finger send message to your brain, along with the visual cues of seeing me do it, along with, your trust level of me going into it.
Oh, I get it. That's why it's better when I brush my own hair out and not when my mom did it.
Exactly.
Exactly. Calling her out.
This is why I can pick something on my face, but I won't let you do it.
That's right.
Because it hurts more when you do it.
You're just a wiener.
So here we are talking about biological factors, right? We're not really bringing into yet the psychosocial factors. But those factors can affect these biological changes we're talking about. Okay. So, as far as changes, so let's just talk about what a neuron is. So, a nerve cell is so it's got all these little arms or dendrites, as I think they're called, and they can have sensors. They can reach out and communicate with neighboring neurons
Reach out
or
and touch
nerves.
me.
Well, they don't actually touch.
I just, I have to, it's my high ADHD.
So, on the sensor end, once it senses enough to trigger an electrical signal, that electrical signal travels down the neuron to the other end to what's called a synapse. So these neurons don't actually touch. There's a little gap called a synapse between them.
I remember high school.
Now, once that electrical signal reaches the end, it spits out these molecules called neurotransmitters or neuromodulators. We're not going to get into what they are and what they do because
You want to so bad I can see your face.
this is where we get horribly in the weeds. There's so many different varieties, but these chemicals get spit out in the synapse, and there's receptors on the other side. And if enough of those receptors get activated by binding with one of these neurotransmitters, it'll create an electrical signal in that neighboring neuron, and the whole process continues down the chain. So when we talk about changes, once the system starts seeing danger, one of the main changes that can happen is it starts spitting more of these neurotransmitters into that synapse. So that message is going to be carried through the next neuron much easier because they're spitting out all these neurotransmitters. So think of like if I want to communicate a danger message to you, our brains aren't physically connected. We don't have telepathy. So I have to spit neurotransmitters at you in the form of words and body language. So I have to communicate that message across the gap between us, right? Now, if I start seeing more danger, I'm going to yell louder. I'm going to spit more words at you to get that message across more clearly, right? And you're going to become more receptive. You're going to become better at receiving that message. So on the other side of the synapse, more of those receptors will be made for neurotransmitters associated with danger. So those are always changing too. So we're spitting out more neurotransmitters into the synapse. We have more receptors to receive more of them. So the likelihood of that message being carried forward is much more likely. Okay. Are you with me on that?
Yes, but I also have other thoughts floating around because that's what I do. This is why I have to take crazy pills because my things aren't re-upping things. They're not yeah. My things aren't my things aren't taking things.
You're talking in the brain.
Yeah.
But yeah, same idea.
Yep.
So what she's talking about, she takes an SSRI.
Yes. My things don't grab serotonins.
So that's a serotonin reuptake.
Selective serotonin yeah.
So when these neurotransmitters are spit out, any ones that are not bound to a receptor can be kind of reabsorbed.
Yep.
So that reuptake inhibitor is inhibiting that reabsorption. So there's more serotonin floating around in the synapse.
Take the happy, bitch. Take it.
So changes, more neurotransmitters, more receptors, that message is being carried forward more easily. All right. So from your brain's perspective, it's seeing that as more danger. Because I'm just imagining more of that message.
Little brain guys waving and screaming.
That's one way to think about it.
One has glasses.
Now, another interesting thing is these sensory neurons. They have a short lifespan, like 3 to 5 days for most of them. They're always being replenished, and it's kind of a supply and demand system. So when we start detecting danger, our body's going to make more sensory neurons to detect that specific variety of danger.
Some of us are working overtime.
More sensory neurons to send more danger messages, and they're getting more efficient in setting it. So think like if you've had an injury, the area around that injury becomes sensitive, right?
Yes.
Where even a light touch or air blowing across it can be painful.
Yes.
That's a direct result of more sensory neurons being created in that area.
Stay away from it because it hurts.
Right. So just a light touch is now sending enough of a message to the brain that it's interpreted as dangerous. And your brain knows you recently injured it.
So don't do it again, stupid.
Yeah, leave it alone. Um,
Ground control to Major Tom.
I'm just thinking what I want to say here.
Don't go too deep, please.
I'm trying not to. That's what I'm thinking through. How do I say this without
I'm trying to save us all.
starting
Feeling.
a whole nother,
Oh God.
tangent?
Get off my microphone, cat.
So in these synapses, there are also stress sensors. And this is why stress is so intimately tied to pain a lot of times.
He's eating my microphone.
Gosh. There are sensors that detect stress chemicals,
Yes.
like cortisol.
Oh, my favorite.
Um,
Makes me fat.
so if we're stressed,
Yes.
just that stress can be enough. Once they become sensitized, and those stress sensors are changing too, we can create more of them in that synapse. So that's another kind of variable at play there. And each one of these synapses is surrounded by an immune cell.
Immune.
Immune cell, yes. So our immune system is involved as well. This is why we often see a lot of correlation between like chronic pain and an immune condition, like an autoimmune chronic condition,
I'm just a hot mess.
because it all affects everything. Now, jumping into the nervous system. So, where our peripheral nerves come into the spine? What?
Just so many buzzwords.
So, nerves from our arms, our legs, our periphery
Outside.
come into our spine and they kind of collect in the spinal cord and then travel up to the brain, right?
Yep.
So when all these nerves kind of collect and go into the spinal cord, they collect it kind of, you can think of it like a post office or like a hub. It's something called a dorsal root ganglion, which you don't need to know that name. It doesn't matter, but they all collect together before they go up into the spinal cord. And at this collection point, it's kind of making a decision what message to send up the spinal cord. So it's kind of weighing all the messages coming in from the periphery and summarizing it, if you will. Okay. So in this dorsal root ganglion is just a big collection of neurons. And all the synaptic changes we were just talking about are happening there as well. As our system is seeing danger, it's changing, it's learning, it's adapting to that to become better at sending that message. So you have this big collection of neurons. In each of those synapses, we're spitting out more neurotransmitters. We have more receptors. So what can kind of happen is all these neurotransmitters we're now spewing into the synapse, they float around and they can float into neighboring synapses and start activating neighboring neurons. So we're adding kind of danger messages that aren't even coming from that part of the body necessarily.
So you got runaways.
In a way, yeah. So when all this is, collected and, kind of summarized and sent up the spinal cord, it's now being amplified. So that danger message is being amplified to be seen as more dangerous to the brain than it actually is due to all these changes. Okay. Now, the brain is also sending messages down the spinal cord. And normally these act in ways to kind of dampen danger messages, like, based on all the other information the brain is processing. Like, no, actually, I'm fine. I'm pretty chill right now. Like, this isn't as dangerous as the body's sensing it to be. And this is where like things like thoughts and a lot of those other psychosocial factors can come into play. Now, when our danger detection system is becoming sensitized, it can dampen and shut off those descending messages that dampen the danger message. So again, by the time it reaches the brain, it's way louder than it would have been before with the same level of danger. Okay. I know this is a lot of information and it's kind of hard to visualize, but so far everything is just changes are making our system more sensitive to danger and that danger message is being amplified. Okay. Now in the brain, we have the same kind of okay, I missed something. Back to the spinal cord.
Back it up, Terry.
Back it up.
Throw it in reverse.
So the receptors in the synapse, okay, they can open and close based on demand. Um, as it becomes more sensitive, they're going to stay open longer. So, and we're not reuptaking as many of those neurotransmitters, so that message can be prolonged. We can keep firing that same message, even if no external information is coming in through the nervous system from the sensory neurons. Um, this is why, like, when something really scary happens, the effect lingers for a while because our brain is still getting that danger message, even though the danger is past. It lingers because those receptors stay open. Something else called neuronal sprouting. So, again, I think looking at neurons as like people trying to communicate is kind of helpful in this instance. So you have, a specific set of neurons saying danger, danger, danger. The neighboring ones are like, ooh, what's going on over there? So they start moving over there. What?
Again, all the tiny SpongeBobs in his brain running around
Yes.
looking through the filing cabinets because all he knows is fine dining and breathing.
Yes. So the neighboring neurons are like, I want in on this.
They're looking for his name.
Something is happening. I need to know what.
Yes.
All the neighbors come outside and on their porches and they're watching.
They're vacuuming their lawn.
And then they call all their friends.
Yeah.
So another way that message is being amplified, more neurons are getting kind of brought in to that danger pathway.
The house is on fire and all the neighbors are rubbernecking.
Yes.
That's dangerous, people. Don't do that.
Uh,
Stay away.
Now, something else in the brain. So let's move up to the brain. So again, all the neuron synapse changes, they're going to happen in the brain as well. And the way pain is processed in the brain is kind of interesting. We normally think of things in the brain as being kind of like this part of the brain does this part of the brain does that. Pain isn't that way. Pain gets processed in all these areas of the brain. And it's always changing too. So if you did an fMRI on somebody in pain, it's going to change over time what parts of the brain light up. And what we see is that when people are kind of progressing into persistent chronic pain, we see parts of the brain light up instead with like dedicated to like learning and totally flew away.
Grab it.
But we see the areas of the brain lighting up typically kind of changing with chronic pain versus acute pain.
Mm-hmm.
And it's really showing the brain has learned kind of that pattern of pain. Emotion, memory, and learning. There it is.
Ta-da!
Ta-da.
Boo-boos.
Another interesting thing, and I'll explain what this is, but it's called cortical smudging. So we have a part of the brain called the homunculus, which is just an awesome word to say. But it kind of goes from kind of your ear in a stripe kind of up to the center of your head on both sides. It's called the homunculus.
Homunculus.
Yes. And you can think of the homunculus as kind of a sensory map of the body. So this part of the homunculus is like the face, this part is hands, not actually, but um, different parts of it are sensory maps of different parts of our body. That's how, like, if somebody touches you, you know where that is, right? You know,
Because it's stored in the homunculus.
yeah, if the cat rubs up against your leg right now, you know it's touching you on your leg.
I know where he's at.
And, you know, even with your eyes closed, you can point to, you know, even where something is on your body.
It's like when the cops pull you over and they tell you to close your eyes, point at your nose.
Yeah, that's what they're testing.
Never done that. I have not, by the way.
I haven't either.
No. I did it for a friend as she was
I've been given a breathalyzer, but not the.
She was practicing for her police thingy, and we got to volunteer for that. That was the most fun I've ever had. Yeah.
But anyway, when we're in pain for a long time, when this danger detection system becomes overprotective, it starts to blur this sensory map in the homunculus.
Your homunculus gets smudged.
Yes. So we're less able to differentiate where it hurts. And we
Where's
think,
the boo-boo?
yeah, where is the boo-boo? My whole arm hurts now instead of just, you know, my elbow. And this is kind of explaining how a lot of times chronic pain can kind of travel and spread to, you know, I've even seen before where my whole freaking body hurts. Everything is so smudged and mixed up that I don't even know where it hurts. It just hurts.
Hmm.
And
Homunculus.
again, this is a protective move by the brain. If, you know, there is something really wrong with my hand and it smudges our sensory map, it makes it harder to use that hand. So I'm going to be less likely to further injure it because the brain's seeing all this danger messages coming from that part of your body. So,
Homunculus.
yeah, really interesting stuff. And if you have any interest, really looking at how they've mapped that out in the brain is really interesting stuff. But anyway, these areas start to overlap. They get, you know, we lose definition. And a lot of the recovery process from chronic pain can include ways of bringing back that kind of clarity to the brain of what sensations are happening where. Any questions about any of that? I know we went through a lot and some of it was kind of technical, but again, the basic idea is that our brain, our nervous system, and our body learns when it sees danger to get better at seeing that danger and to get better at keeping us away from it.
And then sometimes it freaks out and does it all the time.
Sometimes it gets too good at it.
Homunculus.
Homunculus. Word of the day.
Boo-boos, eh? Oh. And we're professionals.
But the good news is learning is a two-way street. You know, it can learn the other way. It can learn to be less overprotective.
He can settle his ass down.
Yes, it can. And this process is always happening in every moment of our lives. Our danger detection system is seeing danger, adapting to it, learning from it. And, you know, I think we could probably go through a lot of examples of the brain learning to be less protective. You mentioned tattoos earlier. Like,
oh, yeah.
Your first tattoo is probably the most painful.
Nope.
Well, depending on where it is.
My last tattoo was my most painful.
Throw that out the window.
No, my first one was it was a very yeah, it was a long time ago. Good God. But yes, it was painful.
But with repeated exposure to it,
Oh, sure.
your brain learns, your system learns that it's not as dangerous.
And now I'm excited for him.
I like using the example. So, back when I was in the military, we did martial arts training.
I was just talking about that yesterday.
We did something called body
Body
hardening.
hardening.
And the intent was to make kind of defensive maneuvers to like block punches and kicks and stuff with parts of your body less painful.
Hmm.
So we would beat on these sensitive parts of our body repeatedly uh, to desensitize our danger detection system. I mean, it was taught to me totally wrong now that I realize it, that we were somehow like damaging and deadening nerve endings, and that translated into less pain. It's totally not what was going on. Um, we were training our danger detection system does not see that as big of a danger as it did initially.
This happens all the time. It's fine.
And there was an interesting kind of progression through that process where, so most of these courses were like several weeks long. The first week you start doing body hardening, that second or third day, it hurts way more than when you started.
My God, you would come home just
And you're just like, this is torture. But at the end of that first week, into the second week, the change starts to happen. It starts to be less painful. And by the end of the third week, it's not a big deal to take blows like that in sensitive parts of your body. And so you see that progression of this learning. At first, it's like, holy shit, what's going on? This is not right. And it gets more sensitive, it gets more protective. And I always remember like that second, third day of these courses, it's a struggle to get out of bed.
I remember those.
Because your brain's telling you in every way possible, like, you don't need to go back.
Your body didn't look great either.
So you go through that oversensitization process, but through repeated exposure, repeated practice, it starts to realize, well, okay, nothing tragic has happened here. And it's becoming routine. So then it starts to go the other way. But I have seen certain individuals that just, I guess, aren't cut out for that. They're very fearful of it. They're very avoidant of it. They catastrophize it. And they go through a different trajectory where it just gets more and more painful for them.
I mean, to me, that would be your brain saying common sense. They're beating the shit out of you every day.
But I remember being told time and time again, it's a mind game. It's a mind game. It's all on how you think about it. It's all how you frame it in your mind. And that's so true because you're affecting a lot of those biopsychosocial factors that contribute to your experience of pain. If I approach it like, yes, this is going to get better, it's going to become less painful, chances are it will. If I approach it like, this is torture, this is the worst thing that ever happened to me, and I get more and more afraid of it as it goes on, it's probably just going to continue to escalate.
Yeah, I was literally talking about this yesterday to Carmen because in cheer, she said taking the hits and tumbles and lifting people. I'm like, oh, you can do some body hardening to work on that.
Yeah. And since I haven't done it in many, many years, I've probably lost all of that
I can start weighing
ability
you if you want.
because my system has learned that no, that's not a threat anymore. And it's not something I'm often exposed to.
Do you want me to start hitting you?
I'd prefer you didn't.
Oh, okay. You squeeze my finger. I need some retribution.
You would enjoy it too much.
I maybe. No, you get body hardening every night when you snore and I reach over and smack you.
Oh, I've been training this whole time.
Yes, exactly. You have. You are
Unconscious.
fine. Ladies, your men are completely fine with they get it every night. Elbow here, little punch there. It's fine.
All right. So I think we'll take our next break here and then we'll start to talk about how do we teach it to go the other way.
Sebastian can't wait.
That cat is so spoiled.
He is. You say bye? You say bye?
All right, we'll be back in a moment.
Yay.
Welcome back to our final segment, Esoteric Wellness, and our conversation about pain. So, we went through what pain is, we went through how our danger detection system kind of gets locked into pain, becomes overprotective,
We also learned our $10 word for the day.
homunculus. Brain's full of all kinds of neat words.
Medulla oblongata.
Mama said. Um, so now I want to get into a little bit about, how do we teach this danger detection system to stop creating pain, get us out of persistent chronic pain?
Please.
I want to start though with what's the catch?
Huh.
The catch is that there's no quick fix.
Nope.
Just as it took time to learn pain, it takes time to unlearn it.
The catch is you have to deal with Kyle.
Wow,
What?
that's painful.
Oh, did I'm done.
Um,
Since we're not fancy enough to have sound effects, I'll do it for you.
so yeah, there's no quick fix. There is a fix, but it takes time and effort.
I'm an American. I don't like that.
And like learning anything, any new skill, if you want to learn a new language, it takes time and effort, right? It's no different. You're learning to change a lot of these different biopsychosocial factors that contribute to pain to have a different meaning. And that takes time. That takes effort. That takes consistent practice.
Boo.
Yeah, I know. It's not the answer anybody wants when they're in pain. They want it gone now.
No, I know.
But we have yet to discover a quick fix for this.
Yuck. I know. But is it worth it? Yeah.
Is it worth it? I have a biased perspective,
Well,
but I think so.
when I
And
can sit and see what you were versus now, I suppose.
that's a question I love asking people when they're finished with, well, you're never quite finished, but when they're feeling confident enough to continue on their own, that's one of the questions I like to ask. Was all this time and effort worth it? And time again, I hear things like it improves their lives in so many ways other than just getting rid of their pain, because we really are talking about changing so many of these biopsychosocial factors, which means changing the way you live your life in a lot of ways. And like I said earlier, this is about so much more than just pain. So anyone that's been through it, anyone that's successfully improved, eliminated their pain, I think is, yeah, they're going to definitely say it's worth it. Now, there are also people that have tried and failed and given up because it is hard. And that does happen. I think in some ways, people sometimes just aren't ready to take that on. And, it's tough.
It is. I'm gonna throw my mom at you. make you deal with her.
Hmm.
My mom has been dealing with a lot of chronic pain. She used to be very, very healthy. Never see the doctor, never had any kind of issues or any kind of health problems for God. Growing up, I never had any problems. And then oh God, I don't know. Say what, maybe 10 years ago, all of a sudden just things started hitting. Um Started off with like we weren't sure what it was, running some tests, and they were checking for lupus, and then they came out with like fibromyalgia and RA,
Mhm.
autoimmune things. And then she's been dealing with that for a long time. Different meds, this and that, switching on and off, blah, blah, blah. And all the things that accompany. And now, she did have neck surgery. And now she's having problems with her back. And
The next weak is link.
yep. And, she's struggling with that. And I'm trying to get her to see, maybe it's not, oh, she's done injections. Well, this last one didn't work. Maybe talking to you. And I think it freaks her out. And
I think for a lot of folks, it's tough to accept that it's not a medical problem
I've been there, done that.
because that's the system we're conditioned to navigate. And I think in many ways people can look at accepting like this perspective on their pain is like it being their fault, that it's in my head and I'm crazy. I mean,
Been there, done that.
I've worked with many people who their doctors have literally told them that.
How many times have you and I gone back and forth because about me just saying I'm crazy? And you tell me all the time, you're not crazy. And I'm like, well, medically,
Yeah, this is not a conscious decision. This learning we just talked about.
the pain is real.
It is real pain. It's not made up. They don't want to be in pain. It's an unfortunate position to be in. Absolutely. And to try intervention after intervention, going into it hoping this is going to be the thing that's going to work for me, and then it doesn't. And then the next one doesn't. And then the next one doesn't. It's horribly defeating.
Like we said in the beginning, and so many other times before, when you've been taught to trust the system and this is it, and you will get the answers, and then you keep going and you don't get the answers. And then you do start to feel crazy because it's like, okay, is it me? Is it this? What is it? Do I have some? I've been there. And you and I've gone back and forth. And then I don't know. It's a hard, no pun intended, pill to swallow when you start to question these things. And it's hard to, when you break that down, and I know I've said this before, but even when we went back through my other, health things, when we were trying to figure out what was triggering my inflammation, and we were going through the food things, and, we were going through all of that. That was a whole psychological hell.
Well, I think this too, this goes so far beyond chronic pain, even the processes we talked about. I think all these different chronic conditions are affected by the same biopsychosocial model.
Yep.
Some less so than others, but autoimmunity you mentioned is one that I see go hand in hand with chronic pain all the time. And as their pain improves, their other condition improves. Um, there hasn't yet been clinical studies to prove that, but I see it often enough. And I mentioned those synapses are surrounded by what? An immune cell.
Yeah.
The immune system is intimately tied to the danger detection system because what does the immune system do? Protects us from danger.
God, it's like it's all linked together.
But I can read through a list of different um, diagnoses that have been successfully treated with this type of approach that we haven't really talked about what that is yet, but um so like chronic pain, shoulder pain, frozen shoulder, chronic cough, GERD, lower back pain, thoracic back pain, sciatica, chronic gut conditions like abdominal pain, irritable bowel syndrome.
Why are you looking at me?
No reason.
You look at me.
um, pelvic pain, endometriosis, interstitial cystitis, irritable bladder syndrome, vulvodynia, migraines, dizziness, chronic neck pain, tension headaches, TMJ, which is pain in the jaw, trigeminal neuralgia, tinnitus or ringing in the ears, whiplash.
This is all off what?
What?
What was this a list of?
Things that can be treated in similar ways. Essentially, by training the danger detection system to see less danger, to be less sensitive.
I had a few things on there.
Yes. Now, it's not necessarily curing that, like endometriosis, which is something you have, it's not going to make that go away, but it's been shown to lessen the symptoms.
Okay.
Okay. Knee pain, hip pain, foot pain, um, plantar fasciitis,
Check.
amplified musculoskeletal pain syndrome, chronic fatigue syndrome, chronic hives, tendonitis, um, whole body pains like chronic pain syndrome, complex regional pain syndrome or CRPS, fibromyalgia, um, hypersensitivities to touch, sound, smells, uh, inappropriate sinus tachycardia, myofascial pain, uh, pain not otherwise classified, central pain syndrome, um, numbness or tingling, burning sensations, uh, POTS,
Ooh, Corbin.
pseudo seizures, and repetitive strain injuries.
Hmm. Quite an interesting list.
It is, and a lot of these, like the gut problems are interesting because that seems to be more of a result of the autonomic nervous system not functioning as well because it is intimately wrapped up in this danger message network. And what kind of happens is uh, parts of the autonomic nervous system get pulled into that process, and then they're not doing what they're supposed to be doing. So, like regulating the digestive system, for example.
Listen, I don't know about you, but you talk about danger. We call that stress poops.
Right. That's your danger reaction there.
That's called the stress poops.
Migraines is another common one
Hey.
that that's the sensory neurons in the vascular system in the brain. You said there's not much blood in there, but there are some, vascular networks mainly on the outside of the brain.
Yes, there's nothing in the brain.
That's why migraines have been thought to be a vascular problem, but it's just oversensitization of those sensory neurons. And then they start to perceive the normal flow of blood through the blood vessels in the brain is dangerous.
Mine are ocular migraines.
Yeah, and they, depending on where they are, they can do different things just beyond just
Mine's
pain.
like a kaleidoscope.
Um,
Wow.
really interesting stuff.
I go blind. That's fun.
Um, so an interesting fact is just having this knowledge of the neuroscience of pain has been clinically proven to improve pain over time.
It's like what is it? Knowledge is power.
Exactly.
Thank you, Schoolhouse Rock.
Exactly. And this is one of the few things medically that just having a better understanding what's happening can improve it.
I feel like the rest of the America should just know that phrase in general. Say it out loud one more time for everybody in the back. See there, that was my slide in for the day.
So I hope to see a day where everyone has this understanding of pain, where it's being taught to kids in school. And our doctor is explaining it to us. You know, that's another interesting aspect is in normal medical school, doctors get like, I think last I saw was like 11 hours of training on pain.
Sorry.
Not much, right? So doctors still having this old idea of pain is no fault of theirs, is the
No,
training they've
absolutely not.
received. This information's out there, but a doctor's not going to really get it unless they seek it out on their own.
Well, when you've done 12 years of medical school or whatever already,
Right.
you feel like that's adequate.
So
That's unfortunate.
it is. And something that needs to change. And I read paper after paper of how doctors interact with their patients affects their outcomes.
Absolutely.
So, like we were talking about MRI scans earlier, like if you have chronic lower back pain and you get an MRI and you are told you have degenerative disc disease,
Oh my God.
it sounds fucking scary.
Well, disease. The word disease
Right.
in itself is terrifying.
And they've shown that being told information like that makes pain worse.
Yeah.
And doctors can say things like, well, no wonder you're in pain. Look at your back. Or I'm surprised you're not in more pain.
That's my big gripe that
Like,
these my chart things, you have access to this stuff before you even get an opportunity to speak to your provider. And they have that little like green section. And by God, if you're a little bit over, people lose their shit. When it's like in reality, it's like, that's not.
yeah. And
Eh.
again, it's not doctors intentionally making people's conditions worse.
No, absolutely not.
But they don't understand how they present information has
Yes.
a big effect. I've read other studies specifically on like chronic gut conditions like irritable bowel syndrome. The relationship with the doctor affects to a great degree the severity of their symptoms.
And let's be honest, and again, God love our medical providers, but sometimes they're lacking some bedside manner. I mean, it's just
They don't get training in that.
no, they're smart, they do their thing, they're here to do it, and it's just like, yep, here it is, blah blah blah, out. And it's like, okay, guys, let's I love me nurse practitioners. That's why I feel like their presentation's a little better.
Um, so as far as what hell kind of approach we're talking about, so it's really a non-medical approach to chronic pain. It's not a surgery, it's not a treatment, it's not an injection, because we know that's not addressing the root cause, right? It's not training our danger detection system to go the other way.
According to you, punch it.
Punch it.
Yeah, body hardening.
Well, once it's already overprotected, that's probably not helpful.
Oh, okay.
Let's give it more danger
Yeah.
to focus on. So again, this is going to focus on all the possible contributing aspects in a biopsychosocial model of pain. So really, we're addressing the root cause of why we're in persistent pain. And I don't want to give the impression either that this is only for people that don't have a real kind of structural problem in their body. So, I'll use myself as an example. Again, I've had a spinal fusion surgery. My back is physically different than a normal spine. And I do have physical limitations from that. I have reduced flexibility, for example.
You had that anyway.
I wasn't flexible to begin with, but that's neither here nor there. But you can have real problems going on and still have an overprotective danger detection system. And teaching that to become less protective can improve pain. It's not going to cure real physical structural problems in the body, but it can totally change the way your brain's reacting to it. So I don't want to make this sound like this is only for people with pain and nothing's actually physically wrong. I work with people with all kinds of, messed up body parts and, all kinds of stuff going on, and sometimes really complex cases. But this is still beneficial. So again, it takes time, it takes consistency, it takes effort. Now, what is involved in this? And this is, I think, the amazing part of this approach is that, one big aspect is education, which we did here today. Consistently beating this idea in people's brains that pain is not tied to damage. And it's not something you can tell somebody once and they fully believe it. You know, I teach this stuff every day, and I still, when I have a flare up of back pain, I go down that road for a while. Like, oh, did I screw my back up? What is wrong? I go down the path of thinking something's physically wrong. Even though I know all this and I know it better than most, I still go down that path. So it is hard to accept. It is hard to fully believe.
We have that argument all the time.
Hmm. Hmm.
All the time. Like, why can't I have just done something? Shut up.
Yes. So as far as what's involved, one of the interesting things is it's unique for each person. There are an innumerable number of ways to teach a danger detection system to become less protected. What specific tools and techniques someone might utilize is really different to each person, depending on their experience, what they like, what they don't like, and the specific biopsychosocial factors at play. So, generally speaking, though, education, like I said, is a big aspect. We might focus on changing the way people react to their pain. This is something you and I have done together, somatic tracking.
Oh, God.
Where you're trying to react to pain in a way that's not reinforcing that it's dangerous.
Yes.
So that takes practice.
It's so weird.
It is weird, but it does work over time. We might also focus on like behavior. So ask any behavior scientist. There's no better behavior modification tool than pain.
Snap the rubber band.
However, it's not very ethical to use pain. And as soon as the pain's removed, it's not a lasting effect. But when we're in pain, it changes our behavior in so many ways. We avoid doing things because it might cause pain. It has caused pain.
That's why we don't spank our children anymore.
I think it's more cultural, but
Ah,
um, but that's why we originally spanked children to
yes, that's
get them to stop doing something.
it's getting it.
But yeah, so learning to approach some of these avoidance behaviors again in a safe way, in a constructive way, teaching our brain that yes, these are safe to do. Desensitizing ourselves to specific triggers, maybe. We might also focus on, I mentioned earlier, thoughts play a role. How do we think about pain? How do we think about, things that might be driving pain, reinforcing it? Think more positively. I see a lot of like people catastrophize, and that leads to chronic pain. Like everything's a big deal, everything's a disaster. Yeah, we all know someone like that. We might focus on a lot of on emotions, teaching our system that emotions are safe. You wouldn't believe the lengths people will go to avoid uncomfortable emotions.
You don't say.
Yeah, I'm guilty of that. I was for a long time. So learning how to approach uncomfortable emotions in a safe way. Um,
Please teach your children that.
uh, Focus on potentially like the nervous system itself. You know, are we in fight or flight survival mode most of the day? How do we kind of get ourselves in the parasympathetic nervous system, rest and digest, really tell our brain through the nervous system directly that we're safe. So we're trying to send different messages to the brain and desensitize all those routes that those danger messages go through. And again, a lot of different ways. Meditation, mindfulness is key for a lot of people. Um, and sometimes it leads to the realization that it's something very specific in their life that they're dealing with, a difficult relationship, or maybe um, a difficult job, or something they know they need to do but they're avoiding. Um, Sometimes the pain is so symbolic and it's impossible to ignore.
We've had that discussion.
Like if I have chronic pain in my neck and I'm dealing with something that's a pain in the neck that I keep avoiding dealing with, as soon as I learn how to deal with it effectively, the pain goes away. For example, I've seen things like that over and over, where it's so symbolic, so obvious that you know it's impossible to ignore. Sometimes it's dealing with past trauma from childhood, or even into adulthood, that's what's driving their pain. So sometimes this does require seeking additional help, like therapy or something like that. But
Therapy's great. Everybody should do it.
yeah. Um, so a lot of these practices are like somatic practices. You could think of like trying to think yourself out of pain as kind of a top-down approach. Therapy is a top-down approach. Somatic practices are more of a bottom-up approach. We're teaching the brain through the body that things are safe, we're safe. Um,
Isn't that like that? Is it somatic yoga? Or like that
Yoga would be a
stretching?
somatic practice.
Well,
Yeah.
there's a specific one where it like is supposed to like target like the stored trauma in the body, and you do these things and you end up like sobbing.
Yeah. Somatic experiencing is a way of
Yeah,
working through trauma
it's
through the
supposed to
body.
be like really therapeutic, but like deep, very intense.
It's interesting stuff.
Because they say like and if you're listening to this, like you've got to be into some weird shit. Let's be for real. Clearly that's what we're about, but they say, the cells, the body knows, you store trauma, you store these things, and like he said, it's symbolic. You have this pain in your neck, you have these things,
You're not
and they
storing it like physically somewhere.
well, the body knows these things,
Right.
and they say doing these stretches, and they say, you I might be a little more into some hippy dippy shit than you are, but they say doing these whether it be
There's just multiple different routes in.
yes.
Like EMDR is another really popular one now. And it's all about moving the eyes in specific
Yeah.
ways.
There's another type of the one massage. I can't the if you'd say the word, I'd be like, yes, I can't even think of it right now. I could tell you any other time, but right now it slipped out of my brain. Mhm. But it's supposed to be certain touch and massage, and it's supposed to help like the pressure and things are supposed to unleash, you know.
Yeah.
But
So what this really entails specifically, again, there's a million and one different options. And when I work with somebody in chronic pain, a
shiatsu.
lot of that process, yeah, is figuring out what works for them, what they need, what they like. Um, because yeah, there's so many options out there. Um, and we'll get much more into detail with that in a future episode. I plan to have a fellow coach on the show that also does this work, and we're going to talk more through like what it actually entails. So I know I'm skimming over it here today. This was more about educating on how pain works, but we will get much more into detail about what is the recovery process and what does that look like. Um, but yeah, but I say this takes time and effort, but I think you'd be surprised at how little time it actually takes.
But you have to be willing to commit to it and be open.
I'd say most of the time people can see some pretty significant change in a matter of months, which when it takes 6 months to see a specialist
Sure.
nowadays,
That's not even
yeah,
joking.
that's not a big deal.
Yeah. Which again, there's our healthcare system. Sad.
um, let's see.
Ground control to major sound.
Wow. So if anyone listening is suffering from chronic pain, is interested in working with me,
Ooh,
um,
shameless plug.
it is my show.
Ah,
This was my idea anyway. It's
oh,
our show.
hour. You keep telling me as you drag me into this hour.
um, where was I going?
You were plugging
Yeah.
yourself.
So you can find me at www.kylebondbreak.com. Um, I do sessions online or in person if you're here in my local area. Um, Initial session is free, so you get a good idea of who I am, how I work, what this might involve, without any commitment. Um,
He's not as terrible as I make him sound. I'm just married to him.
and I do sessions for about $75 a session, depending on how many you buy at a time. And I won't just plug myself, some other resources out there. So I also work with a company called Lin Health. That's LIN Health. Their website is www.lin.health. Um, so they're a telehealth kind of set up system. This is more ingrained within the medical care system. So you're going to be supported by a medical professional, mental health professional as well. And if you're referred by a doctor, by your own doctor,
And are they now accepting insurance too?
they are beginning to accept several insurance plans in several states. They're adding more all the time. So it's probably worthwhile checking to see if they do accept insurance. If not, out of pocket costs, and this is always changing, so take that into account, but it's somewhere over $230 a month for a monthly subscription, and that gets you like 4 half-hour sessions a month and access to the app, which is pretty cool. Some things I can't provide. Another resource out there is Curable, uh, curablehealth.com, and it's also a downloadable app, much more affordable, but it is self-guided. You don't have access to working one-on-one with a coach or some other kind of professional, and it's only 12 or $6 a month, depending on how many months you buy at a time. So really affordable, same information, same approach, but it is self-guided. Um, some great book resources out there. A book called Unlearn Your Pain by Dr. Howard Schubiner is a great resource. It's written as a workbook. So he kind of guides you through, I think, a 10-week process, I think. I don't remember. But it's a great process. I've read it. Um, awesome resource, pretty affordable. I think it's like $20 or so on Amazon. Another great book is called The Way Out by Alan Gordon. Um, and both those gentlemen, you look them up on YouTube, find them on the internet. They got a lot of free resources, information out there as well. Um, but yeah, I think this is a field that's growing quickly. I'm seeing a lot of changes in the medical system around it, which is promising. Um,
So he's not just full of shit.
No, this isn't something I came up with in my basement on my own.
You'd have to clean up your workshop
Oh,
to do
yeah,
that down there.
yeah, yeah. But yeah, I love doing this work. I'm consistently amazed at the amount of progress people can make in, like I said, a matter of months.
And you work, and that's another thing I like to think about. You work with people from, you said what your youngest client has been from 8 to 91.
Yeah,
This doesn't just affect a certain demographic, a certain age group, men, women, whatever. It's literally anyone, any age. I mean, it's shocking, you know.
it is. And I think I learn a new diagnosis every week.
Yeah.
They keep coming up with new labels to give chronic pain.
Well, and people want to have an answer to what they're feeling so they don't feel crazy.
Mhm.
And I totally get that.
Chronic
But
pain isn't very satisfying. No.
it's not. It's not. And to be able to have something to make you to satisfy that, and it's like, okay, I finally have an answer. Because when a doctor sits there and goes, huh, that makes you go, oh, well, shit, it's even worse. But then when you can work with somebody and work through it and be like, okay, so this isn't you, this is something we can, really help, not just here's this thing, deal with it, and here's some pills
Mm.
or whatever, you know. But yeah, when you have to come up with something new all the time to cover what we're dealing with, when in reality it's
Yeah.
could just be something as simple as ourselves.
It's an amazing process to witness because um everyone's goal at the outset is to get rid of their pain, but when they reach that goal, they don't even notice. Like, it totally passes them by. Suddenly they're like, I haven't had any pain in 2 weeks. And I didn't even notice because so much of the process is getting back to living your life before the pain leaves. And that's how you get rid of it, which is backwards from the way everyone approaches it. Typically, I'll do all these things once the pain stops.
You've arrived.
Yeah. And that just doesn't seem to work. But yeah, it's amazing to witness, amazing to participate in. And, I've seen it in myself too.
I've seen it. Like I said, when you went from hardly being able to sit long enough to watch a movie to getting back to daily life and then some. I mean, we just went on a vacation where we went hiking and did things that I don't think you would have, I wouldn't have thought you would have been able to do.
I probably wouldn't have done.
No, you know, we,
But now I approach those things without even a second thought.
yeah,
It's just going to hurt my back. Never enters my mind.
yeah. And you were scaling some things without a second thought that I wish you wouldn't have, but that's another whole other thing.
See, there you go, being overprotected.
Okay. Hey, you yelled at me at one point to get away from the ledge, so it goes both ways here.
But yeah, I think that's our show for today. I got nothing else to say.
That's shocking.
Unless you just want to hear me ramble.
No, we don't need pyramids because God knows where he'll
We
go.
did that last time.
Lots of pyramids.
I have to work on though how to tie all this into the esoteric. I got some ideas. I haven't put that together yet.
Oh God.
We'll do some rambling later.
Yay.
But yeah, I've planned several more episodes on this topic. Like I said, we'll do one um, looking more deeply at the process itself, what it entails, what kind of practices it might include. We'll look at a recovery story, someone who's gone through the process, someone who's living their life again in so many ways, and hear kind of that perspective on it. And potentially another episode with an expert in the field. I won't reveal who that is because they haven't
Woo.
committed fully to it yet, but that'll be really exciting if that does happen. And like I said, maybe an episode tying this into the esoteric as well.
You want to hear a fun brain fact?
Let's hear it.
So, you know, the outer covering of the brain is called the dura mater.
No,
That means tough mother. It's one of my favorite things.
tough mother.
Tough dura mater, tough mother. Love it.
Told you the brain's full of cool words.
Medulla oblongata.
Homunculus. We learned that one today.
The pons. Homunculus. Do you title these?
What?
Do you title the episodes?
Yeah.
The homunculus.
Is that the title for today?
The $10 word.
We usually do that after the fact, but
The $10 word. Do you give it funny things, or do you just give it a generic pain?
no, you're the funny one, not me.
Oh, I know.
No, they're usually more descriptive and funny.
Oh, well, that sucks. Whatever. Anyway,
Educational show for the most part.
until he rambles about pyramids,
Hey,
boo-boos.
you brought up Boo Boo.
And I'm over here making SpongeBob references. But anyway, so that's all, folks.
All right, till next time. We'll see you then.
Bye.
Thanks for listening.